displayed a dermatous plaque on both arms, and later on the rash spread to the soles, palms, extremities, trunk, and also the oral mucosa and the eyes were involved. So it was painful with a pain severity score ranging from 6 to 8 out of 10, and it was also itching. So there was also formation of blisters that fractured, releasing watery fluid. So our patient had a history of recent travel to Makambako 4 weeks before admission and reported to have experienced runny nose, mild cough, painful swallowing together with fever.
Is that all, um, Seba?
So this was also associated with fever, chills, generalized body weakness, and loss of appetite. So patient reports to have used some over-the-counter medications, which were named NyQuil together with Mucinex for the symptomatic relief.
Okay. Uh-huh. So yeah, thank you very much. Um, so as we're hearing this story, and as I started the case, saying that if we hear this how this rash evolved and it where it involves, we can say whether there is a systemic disease causing this rash, or versus this is a, a localized skin disease presenting as a rash. But as you can see here, this is a symmetrically, uniformly distributed rash. So we are sure at the end we will have a systemic disease which presents itself as a rash. So when you hear a rash, a generalized rash like this, a lot of differential diagnosis. You should be able to pinpoint some very specific pointers that can direct you to one diagnosis vis-a-vis the other diagnosis. And I've seen two things in this rash. For example, one, it involves the palms and soles. If you see any rash involving palms and soles, you shouldn't waste your time. Go on whatever search engine that you're using, Google or ChatGPT, or maybe whatever you're using, and type in to see the differential diagnosis. It is not that broad. Another thing is, I saw like this rash is. Can you go back to that slide, Seba? Yeah. So it is blistering. So that's also very important. Not many rash are blistering. So blistering rash involves palms and sole. I'll pinpoint and diagnose and discuss particularly on that, and I believe we can have something useful at the end. So for me, when I hear a rash that involves palms and soles, I think the palms and soles are very crucial parts of the body. They're different from other skin parts. They're so hard compared to other skin. So it requires the disease to come from inside and penetrate the palms and soles so that it can show up on that places. And what you have here include infectious diseases, autoimmunity, and others. So if we start with infectious diseases that can present themselves on palms and soles, you all know one of the markers of infective endocarditis, I think, is January lesions or something. It presents on the palms and soles, but this I believe won't be the case at the end, because we know that blistering diseases is not among the presentation of infective endocarditis. Again, uh, uh, toxic shock syndrome is another infection that can present as such. The other thing, the other infection, if I try to remember, rickettsial diseases. Yes, so rickettsial diseases can present with a rash that presents on rickettsial infections on the palms and soles. And I remember that we had a case here. David was discussing, and I said something like he pointed out like, do we have rickettsial diseases here? And the answer is yes. We have them in East Africa. They have been recorded. For example, the African tick bite fever. That's a rickettsial disease, which is caused by I don't know, Rickettsia africae. Yes, Rickettsia africae. So those things are also present in this place. But these cases are from AfroDX. It's not from Tanzania, so it's elsewhere. They have the rickettsial diseases there. And HIV, acute HIV can present with a rash, and they can be distributed. They can involve the palms and soles. And lastly, which is very important, is secondary syphilis. You all, you all learned in medical school, second year, I believe, that among the presentation of secondary syphilis is a rash that involves the palms and soles. Uh, what other what other diseases that can be there? Infections, yes, I think we've done a good job there. Yes, medications. SJS10, Steven Johnson syndrome, and its associated 10 can also present with the rash, which can involve the palms and soles. But if you mention SJS, you should also mention the differential diagnosis, a close differential diagnosis, which is erythema multiforme. This case, the distribution, and then being presenting with the blisters, maybe it will end as a case of SJS10. So we will hear on the the exam findings of these blisters that we have. We will hear on the exposure history of this patient with the medication that he have used, and we can decide on that. Other diseases can present with a rash that we will involve the palms and soles. I think yes, there is a list, but for now, I can mention that medications, infections. I don't think of any autoimmune disease that can present with this. Um, yeah, sometimes, but no, reactive arthritis doesn't do that. Psoriasis, less likely. Yeah, so I think we can proceed from there, Seba, and see where I can put this.
Thank you, Dr. Joseph. So in the review of other systems, and the musculoskeletal system, there was not any joint swelling or muscle pain. In the CNS, there was no headache, convulsions, any history of blurring of vision or loss of consciousness. So in cardiovascular system, there was not any difficulty in breathing or lung clots or lower limb swelling. In the GUS system, no painful urination or history of urethral discharge that was reported. So anything you want to discuss there, Dr. Joseph? The review of other systems?
Um, yeah, so uh, the GUS is important. Like I said, one of the differential diagnosis can be secondary syphilis, and STIs usually travel together. So it's important to review something like that because one can present with syphilis and maybe gonorrhea or chlamydia at the same time. Musculoskeletal, so no joint pain, and the CNS is okay. Yeah, I think not much to discuss here.
So in the past medical history, our patient had a history of ADHD as a child and also has a prior history of substance use disorder, but is currently in remission for more than 5 years. And for the part of medications, our patient has no any history of chronic medication use, apart from the ones which he used during the 4 weeks ago when he had an respiratory infection.
Okay.
So in the family and social history, our patient is in panic. He's married with two children. So he's a smoker, but non-alcoholic. There is no history of multiple sexual partners, and there is no familiar history of similar illness. He's confident. So in the general exam, our patient was fully conscious. Currently, the patient is a febrile, not pale, not jaundice, no lower limb edema. In the part of vitals, the respiratory rate is 17 cycles per minute, saturating 98% with room air. So blood pressure was normal, but he had a tachycardia of 106 beats per minute. So in the integumentary system exam, our patient had a circular alternating to oval erythematous maculus, also papules. There is also a mix of vesicles and mullae together with erosions, in which some of them have irregular margins together with the targetoid lesions of variable size, so being surrounded by an erythematous rim. So they are symmetrical and they are widespread, affecting the trunk, extremities, and mucous membrane, especially the areas of pressure such as the sacrum and the buttocks.
Hmm. Okay, so yeah, thank you. I think this is the most important exam finding here, and we should discuss it before proceeding. And so, let me admit some people. Okay, um, the exam is so typical that this patient has an evolving rashes, but at the end of the day, they are generalized and they are um, vesicular bullars and the erosions. So this direct to just one point, we are dealing with blistering skin diseases here. And if we can pin down the differential diagnosis, we can have the final diagnosis of this patient from just this slide. I've mentioned some, and which involve the palms and soles. I've mentioned the SJS10, erythema multiforme, and but there are others. So bullous pemphigoid is one, pemphigus vulgaris is another, and what else do I know in that part of that diseases? I think I'm limited, and I'll be learning from you at the end. But yeah, I am there, and so another very important thing is their targetoid. So two words that dermatologists use: targetoid versus target, and I usually remember them by how they end. Like targetoid, it ends with a D, which I think means double. So it's two layers, while the target ends with a T, three layers. So the targetoid, um, I believe, points to the direction of SJS10 more than erythema multiforme, which have target lesions. Plus, it involves the mucous membrane of this patient. So yeah, I'll be there, and my differential diagnosis will rest there. Having the rashes that have erosions, they are taking us away from bullous pemphigoid, which are usually not don't have erosions. The pemphigus vulgaris have erosions, but we don't expect them to see in a 34-year-old. Probably we see them in elderly patients. So first DDX here, SJS10 more than erythema multiforme. Can you proceed?
So thank you, Dr. Joseph. I think that is perfectly explained. So the other systemic examination, cardiovascular system, our patient was tachycardic, but other parameters were all normal. Abdomen exam was normal, respiratory exam was normal, and the musculoskeletal exam was also normal.
Yeah, we can.
So in the parts of lab which were done, CBC had normal parameters. The latest electrolytes, the patient had normal electrolytes. Also, the liver enzymes, together with the renal function tests, were within normal limits. Also, a patient tested negative for herpes simplex virus, also the varicella zoster. Also, triple seroid was also negative for patients.
Yeah, so these labs are also remarkable because they rule out some things that we already talked about. For example, VDLIL being negative, um, it rules out even it rules out an active syphilis in this patient. HSV and two, yeah, they we don't expect them to present like this. By the way, VZV, not bullous, I believe, and yeah, I don't see others to discuss in these labs. What I have in this patient is something which will should be made probably clinically. Yeah, maybe we proceed. Yeah, so here is I have to have my diagnosis. Yeah, so I think not much to say here, Seba. From the way I started this case and the way I'm seeing it, it's a bullous skin disease in a young patient who was exposed to some medications. Like you said, 4 weeks.
Yeah, 4 weeks.
Yeah, and what were the medications? I didn't see anything, a culprit there. Like, do you remember the meds?
Yes.
The meds that he was exposed
So
on?
it's a brand. Yes, it's a brand name which is known as Liquid, together with another one which is Mucinex.
Yeah, so I don't know those brands. Maybe I don't know, but you know what I'll be doing. I'll Google them, see what is their generic names, and whether they can start this SJS10. I'm sure this is a final diagnosis, and sometimes I remember reading this that you can have SJS10 and you cannot pinpoint to a medication that the patient was exposed to. Should I consider other diagnosis? The closest thing you can think of in SJS10 is erythematoform. I think that's not the case in this patient. Yeah, I don't have much. Maybe I'll be hearing from you, teaching me, Seba. I think it says SJS10.
So yeah, thank you again, Dr. Joseph. I think that is excellent. Done. So provisional diagnosis, as you have said correctly, we are dealing with SJS thing. So just some few learning points. So SJS 10, this is we call them dermatological emergencies, which is the severe cutaneous adverse reaction, which are characterized by extensive necrosis and detachment of the epidermis from the dermis. So usually the mucous membranes are affected by more than 90%, but also you can have ocular involvement, which is also commonly reported up to 70%. So typically they present with the cutaneous lesions as our patient had, which were involving the trunk initially, then later on it spread into other parts of the body. But of specific importance to note here is that the scalp is usually not affected in patients presenting with SJS10. So usually there is a formation of vesicles slash bullae, which are usually flaccid, so very easy ruptured, and also they tend to have a sheet-like skin detachments. And a very important sign is the Nicolisc sign, which is the detachment of the skin upon application of pressure. So it's a T cell mediated uh, immune response against the epidermis in an individual who is genetically predisposed. So there's some of the HLA which has been heavily studied to be associated with SJS10, which is HLA-B star 5801. Also commonly, it's the HLA-B star 1502. So there are a number of risk factors which have been reported. Our patient did not have any of these. So HIV is high on the list. Also, connective tissue disorders.
Mm.
High on the list is the systemic lupus erythematosus. And also, particular importance is that SLE, especially the cutaneous SLE, is an important differential when you are dealing with SJS10 spectrum. Also, malignance, individuals with malignance is also a risk factor of SJS10. Also, older individuals, 50 years and above, are highly prone to have SJS10 in comparison to younger patients. So, as Dr. Joseph, you have said correctly, majority of the cases are attributed to high-risk medication. But in up to 25% of cases, you can have no clear drug causality.
Mhm.
So up to 25%, you can have recordable cases of SJS10 without having a possible culprit drug. So in circumstances when you don't have you fail to pinpoint exactly presence of the drug in causation, so you have to think of infection should be considered. And high on the list, the one which has been heavily mentioned is the mycoplasma infection, and also the viral infections such as the herpes simplex and the varicella. So there are some rare reported exposures which have been also linked with SJS10. So there are individuals whom are exposure to herbal medications and some other type of food have been linked to causation of SJS10. So this is just a table which summarizes drugs according to stratifying the risk in causation of SJS10. High on the list is allopurinol, together with uh, anti uh, anti-epileptic drugs such as carbamazepine, lamotrigine, phenytoin, phenobab. Also, another drug which is high risk is sulfur-containing drugs such as the cotrimoxazole, together with the sulfasalazine. Also, antiviral drugs such as nevirapine also are high risk drugs in causing SJS10. Also, oxtam derivative NSAIDs, the one which has been highly implicated is meloxicam. So there are some of the drugs which fall in the moderate risk category, such as the cephalosporins, macrolides, and the quinolones. But also there's drugs which are low risk includes mostly these are antihypertensive, the beta blockers, ACE inhibitors, and the calcium channel blockers. So just a quick picture which shows the overlap between SJS10. So SJS10 is is just a continuum of the same pathology. So the cutoff point is usually based on the body surface area that is affected.
Mm.
So SJS is usually when you have less than 10% of the body that is affected, that is SJS. So body percent from 10 up to 30% is known as the SJS10 overlap. And when you have more than 30% of the body being affected, then it's a toxic epidermolysis.
Mm.
So diagnosis is usually clinical, as Dr. Joseph took us through. So usually the role of skin biopsy is to confirm the diagnosis. There are some of the typical features which are usually seen, which is the detachment of the epidermis from the dermis and also significant apoptosis of the keratinocytes. Usually in the management of the disease is the first and foremost thing is identification and withdrawal of the offending drug if the offending drug is found. Also, there is assessment of the severity of the disease. So there is a special score that is known as the spotting score that is used in the assessment of the severity of the disease and also to prognosticate patients who have succumbed SJS then. Also, the mainstay of therapy is supportive care, that is wound care, so as to be able to reduce the risk of getting secondary bacterial infection, which has been shown to be one of the significant causes of mortality in patients with SJS10. So adequate fluid therapy, electrolyte management, specifically potassium, because these are patients who are usually succumbs to hypokalemia. Also nutrition which is rich in protein. Also management of the temperature so as to avoid hypothermia and also pain control. Also ocular care is important. So there is a role of oral cyclosporin, especially in the early course of the disease within 24 to 48 hours, which has been shown to have a significant mortality benefit up to 60%. Role of systemic corticosteroid is not well established, although it's a very common practice in our setting. And also, I said initially, these are dermatological emergencies which are associated with very high mortality in case they are not managed properly. So the recorded mortality numbers is up to 25% of the cases. So thank you, Dr. Joseph. You're welcome.
Yeah, thank you very much, Seba, for preparing the slides and adding a lot in that teaching points. The most important thing I took there is I didn't know that 25%, and then you you can't identify a culprit. That's so interesting. But yeah, so this is a nice short case. It have pointed my holes. Now, if I go back, I'll have to sit and again read on the bullous skin diseases. I think I have a very narrow diagnosis. Plus the other diseases that can affect palms and soles, because those are the only two things. If you have them, you have the diagnosis in this case. Um, yeah, maybe if we can hear from the flow, any question, addition, experience that you have had managing diseases like this. I see David joined late.
Hello, Joseph.
Yeah, how are you, David?
All is well. So I I am on the road, so I couldn't join on time.
Yeah,
So I just thought now that I have the internet, I thought I should come and see
yeah,
what transpired in the past several minutes to 1 hour.
yeah. No
But
worries.
happy to see everything went on, and I hope you recorded so I can follow
Yes,
and not miss a single Afro DX case. Thank you very much.
sure. Karibu. Yeah.
Sansa.
So, anyone, guys, from the flow with anything? Okay. Since we started late and we took a lot of your time, if there is nothing else, I'm happy to maybe welcome you again the next Sunday that we have another case. Thank you very much and have a good night, all of you.
Yes. Night.
Thank you.